If you want to get extra, you have to do extra. Hello dear friends, myself Dr. Shrikant Verma. Very warm welcome to all of you at our conceptual brainstorming integrated session of anatomy at this amazing platform. So right now we are going to look for this our thyroid gland. Thyroid gland is very important. One question show from this unit either related with the our surgery, medicine, ENT, physiology, pharma, or the anatomy. So all the basics come from the anatomy. So we are going to look for the anatomical aspect with integration to the other different subjects. What are the different points which we are going to learn in this unit? We are going to see the thyroid introduction. Then we will see the parts of the thyroid gland. Then we will observe the location and extent of the thyroid gland. We will observe regarding the capsule of the thyroid gland so that we can understand the surgical process of the thyroid. Then we will observe the different other viscera and structures related with the thyroid gland. Then we will see the artery, vein and lymphatic drainage. Then we will observe regarding the histology and the development. We will see the clinical points. Then you have to learn regarding the your surgery, medicine, patho, physiology, pharma and other subjects. So let's start this topic with the introduction. First point. Yes, sir. The thyroid gland is the first endocrinal gland which is getting developed in the body. MCQ. Yes, its shape is just like the shield. Yes, old time shield which was used by the gladiator, by the warrior, according to which, yes, it is named as a thyro. Thyro means shield. Yes, thyroid gland, it is having the shield like shape. What is the importance? It controls the basal metabolic rate. Basal metabolic rate it controls. Yes, it is very important. It is controlling the basal metabolic rate of the body, each cell, each organ. So it is very important for the proper development of the body as well as brain. Getting the point? So if there is a thyroid problem, the proper development of the CNS, central nervous system, as well as body is not possible. Okay, sir. So now we are going to look regarding the thyroid gland parts. You can observe in this image, thyroid gland, it is located in the neck. First point. Where, sir? It is located in front of the our trachea. Yes, sir, in front of the trachea at the lower part of the neck. Yes, you can observe this thyroid gland is having the different parts. It is having the right lobe, and yes, this is the right lobe, and here is the left lobe, right and left lobe, which are joining together with the help of the narrow part known as the isthmus. Yes, you can see it is having the one uppermost pointed part, that is the apex, and this is the lower part known as the base. Getting the point? It is located in between the two sternocleidomastoid at the lower side. Now these points you can remember. The notes for all of you. See here, parts. It is having the three lobes. How, sir? Sir, there is a right lobe, there is a left lobe, but also sometimes one small pyramidal shaped lobe is present just above the isthmus. Remember, it is attached with the fibromuscular band. Yes, it is fibrous in nature, fibrous connective tissue, but few element of the muscles are also present. So fibromuscular band. This is contracting and elevating the thyroid gland above. That's why what is the name? Levator. Yes, it is elevating. Elevating to what? Gland. That's why levator glanduli. Which gland? Thyroid gland. So this our small fibromuscular band is known as levator glanduli thyroidi. So remember this name. Now look for the our different points. Sir, thyroid gland. It is having the right lobe. It is having the left lobe, and these are attached with the narrow junction known as isthmus. Agree, sir. Now I told you the thyroid gland is having the apex, the thyroid gland is having the base. Yes, sir, there is the right lobe, here is the left lobe, this is narrow part isthmus. Remember, there is a small pyramidal lobe just above the isthmus. It may be present or may not be present. So this is the our, yes, you can say pyramidal lobe. This is attached with the fibromuscular band which is known as levator glanduli thyroidi. Sir, this is the levator glanduli thyroidi. Now look, the thyroid gland is protected by the collagen, by the fat, by the capsule. two types of the capsules are present. Yes, sir. The outside capsule is the false capsule. Yes, sir. It is our outside capsule. False capsule. Do you remember? In kidney also you will observe, जो दूर रहता है वो झूठा होता है. Yes, it is away. This is false capsule of the thyroid gland. Okay, remember it is made by the condensation of the connective tissue and fat which are located outside. But there is a one more capsule which is firmly attached with the gland. Yes, the capsule which is firmly attached with the gland, that is our, remember, this is the our true capsule. This is the our true capsule. Getting the point? Yes, sir. It is our true capsule. This true capsule cannot be separated from the gland. Why? Because this true capsule is formed by the substance of the gland. And one very important point I will tell you. Yes, this is our which capsule? ट्रू कैप्सूल. रिमेंबर, जो पास होता है, जो अंदर होता है, वो सच्चा होता है. ट्रू फ्रेंड्स दे आर क्लोज, while the false friends they are away. So this is outside while the true capsule is inside. Getting the point? Okay, so these are the important MCQs. Later I will teach you that our, yes, thyroid venous plexus is located just below the our, you can say, the true capsule within the thyroid gland. So this is the our thyroid venous plexus. It is located below the true capsule. That's why in surgery you will learn that whenever you are performing the thyroidectomy operation, you have to do the incision in between the true and the false capsule, because here no thyroid venous plexus, so less bleeding. A good surgeon is the surgeon who is doing less bleeding, who is damaging less blood vessel, so he will do less bleeding, less chances of the shock, less chances of the death of the patient. So this is the your plane of thyroidectomy. This is very important integration with the surgery. Yes, sir. Surgery, anatomy, conceptual brainstorming integration. Remember, beta, it is very, very beautiful concept for your surgery when you will get when your anatomy is strong. Now, come to the our next point. Yes, sir. I told you these parts. Now we are looking for the situation and extent. MCQs are directly asked from this part. Again, I want to tell you, direct question from the thyroid in anatomy, they are rare because it is having the more and more important points in the your clinical. So clinical questions are asked. Okay, so for that clinical questions, we are making the base in our anatomy. So what is the vertebral level of the thyroid gland? MCQ. Sir, it is located from C5 to T1 level. One thing you can remember, it is the same vertebral spinal root level, better to say spinal root level of the brachial plexus. Sir, brachial plexus root was formed by the C5 to T1 spinal root. But here we are talking about the vertebral level. Okay, so vertebral level of the thyroid gland is also same, which is the spinal root value of the brachial plexus. Two MCQs. Yes, with the single arrow, we are covering the two different MCQs. Now, the tracheal level. Thyroid gland is located in front of the our trachea. Remember, it is extending in between the our thyroid cartilage up to the tracheal ring. Okay, so which part of the thyroid cartilage? Remember, middle of the thyroid cartilage. It is starting from the middle of the thyroid cartilage and it is reaching up to the T4th or T5th tracheal ring, C-shaped ring. Yes, hyaline cartilage ring. Okay, so this is the another MCQ. One very, very important point. Yes, sometimes this dimension may help, direct questions are not asked, but for the surgery it will be important. What is the dimension? So in easy way you can remember, sir, it is having the dimension of the 5 centimeter length, then you can say the width and depth is the 2.5 and 2.5 centimeter. I did just approximately value, no need to mug up. And the isthmus is narrow part which is having the 1.2 centimeter length and 1.2 centimeter width. Okay, now look the weight. Just sometimes it may be asked, especially for the first MBBS students, not too much important for the NEET PG, but you can remember it is having the weight of the 25 grams. 25 grams. Remember, parotid gland, you will learn in the your ENT that parotid, P for parotid, P for 25, P for parotid, P for 25. You can remember 25 grams. The same weight is having the thyroid gland also. While the submandibular gland, it is 20 grams. While the sublingual gland is approximately 5 gram. Better to say 3 to 4 grams, you can remember. Okay, so just a few data. Now look here. This question had been asked many times in your surgery. Sir, the isthmus of the thyroid gland. The isthmus of the thyroid gland, it extends from the second to the fourth tracheal ring. So remember, 2 2 ja 4, second to fourth tracheal ring. One diagrammatic presentation for this all you can observe here. Can you see? Sir, midline structure of the neck in ENT you will learn one chapter. So uppermost part, sir, there is the hyoid bone. Yes, sir, this is the hyoid bone. Fine. Now look here, below the hyoid bone you can observe, sir, there is our thyroid cartilage. Yes, sir, this is our thyroid cartilage. Okay, sir. Now look, there is the our thyroid gland. Yes, there is the right lobe and here is the left lobe of the thyroid gland. Now both are joined together with the help of the narrow portion isthmus. I told you above, along the upper border of the isthmus, there is the presence of the pyramidal shaped lobe, pyramidal lobe. Okay, sir. Now I told you that this thyroid gland is covered with the help of the capsule. So outer one is the our false capsule, while the inner one will be the your true capsule. Yes, inner one is our true capsule, and just below the true capsule there is a presence of the thyroid venous plexus. Yes, sir, we completed this all. Now observe, there is the fibromuscular structure levator glanduli thyroidi is attached in between the our hyoid bone and the pyramidal lobe. Now look, the apex of the thyroid gland, sir, it is related up to the C5 vertebra, while the base is related with the T1 vertebra. That's why I told you the vertebral level is C5 to T1, just as the our brachial plexus root value. Now observe further more things. Yes, sir, you can observe that in our next image capsule. I told you just one notes, sir, the two types of the capsule, true capsule and false capsule. True capsule is inner, false capsule is outer. जो पास होता है, जो अंदर होता है, वो सच्चा होता है, जो दूर होता है वो झूठा होता है. Yes, the true capsule is formed by the substance of the gland. That's why you cannot separate it from the gland because it is firmly attached. Okay, sir. But just opposite, the false capsule is the condensation of the connective tissue fat outside in front of the trachea, pretracheal fascia. MCQ, the false capsule is nothing, it is the modification of the pretracheal fascia. Remember, inner surface is thicker, its inner surface is thicker. Yes, what you have to remember, its inner surface is thicker, which is getting thickened and attached in between the cricoid cartilage. So it is making one ligament. Very important point. Focus here, sir, it is making the suspensory ligament of the berry. It is making the suspensory ligament of the berry. What you have to remember, sir, this is our thyroid gland. Yes, thyroid cartilage. Just below the thyroid cartilage, can you see the cricoid cartilage? Okay, sir. And then there are the presence of the tracheal ring. Okay. Now you can observe in this image, sir, there is our thyroid gland which is reflected. Yes, here is the one ligament attached between the thyroid and cricoid cartilage. Mark my word, mention my word, listen carefully. It is attached between the thyroid gland and the cricoid. Remember cricoid, I'm not telling you the thyroid cartilage. Yes, this is suspending, this is holding the thyroid gland. Okay, so remember this is the MCQ, that suspensory ligament of Berry. Yes, it is a modification of which fascia? Four option: prevertebral fascia, pretracheal fascia, buccopharyngeal fascia, pharyngobasilar fascia. Use common sense. Sir, this thyroid gland is located in front of our trachea. It is located in front of the trachea. Okay, sir. It is located in front of the trachea. Fine. Now what you have to remember? Sir, if it is in front of the trachea, so the suspensory ligament of the berry, which is attached between the cricoid cartilage and the thyroid gland. Yes, it is modification of what? Yes, just similar like that phenomena. जो नदी जहां रहती है, जहां बहती उसे एक सप्लाई करती है, जो फेशिया जहां रहती है, जहां बहती है वहां के मॉडिफिकेशन को बनाती है. बिकॉज इन फ्रंट ऑफ द ट्रेकिया देर इज द प्रीट्रेकियल फेशिया. So this pretracheal fascia will make the suspensory ligament of Berry, which is attached between the cricoid and our thyroid gland. Simple. Now look this clinical importance. I had written the notes for all of you. Remember, suspensory ligament of Berry. It forms basis of the movement of the thyroid gland with deglutition, which is our deglutition test. Remember beta, whenever we are swallowing, ENT and surgery integration, whenever we are swallowing, the thyroid gland is also moving. Yes, you will ask the patient to extend the neck and then you will ask to swallow. When we are swallowing at that situation, the thyroid gland is moving. Why? Because when we are swallowing at that situation, yes, our pharynx is having the attachment with the help of the thyropharyngeus with the thyroid and cricoid also. Okay. So the thyroid and cricoid, they are moving. Now the cricoid cartilage is attached with the help of the suspensory ligament of Berry to the thyroid gland. So thyroid gland is also moving up and down. So it is very important. Why? Because if any tumor, any cancer, any mass is arising from the thyroid gland, then with the help of this deglutition test, you can differentiate that that particular mass is actually arising from the thyroid gland, yes or not. If it is not attached with the thyroid gland, like the lymph node and other things, it will not move with the deglutition. This is your deglutition test. Learn in your surgery medicine, but the basics are coming from the anatomy. Now I told you the venous plexus, they are just below to the true capsule. Thyroidectomy should be done in between the falls and true capsule. Another beautiful concept of our surgery. Agree beta? Fine. Okay sir. Now look for this our concept. We are correlating the thyroid surgery and the prostate surgery. In abdomen session, I will tell you, sir, suppose this is our thyroid gland substance. Okay, sir. Now the thyroid gland is having the false capsule and the true capsule. Yes, sir, false capsule and the true capsule. And the thyroid venous plexus is located just below the our true capsule. Fine, sir. That's why we will do the thyroidectomy operation. In which plane? Sir, in between the false and the true capsule. Why? Sir, because there is a no venous plexus. But if you will cut here the thyroid gland, all the venous plexus, they will celebrate happy birthday. Yes, they will get injury, there will be the bleeding, and there will be the shock, and there will be the death. Getting the point, everyone? Fine. Now, what you have to remember? You have to remember in our prostate gland, just opposite. Sir, this is our suppose prostate gland substance. Here is also the true and false capsule. False is away and true is below. Yes, false is away, true is related with the prostate gland. But here the venous plexus is located between the true and the false capsule. So if you will do the prostatectomy operation here, then the venous plexus will get damaged. There will be the bleeding and shock and the chances of the death. That's why transurethral resection of the prostate is done from the inside. Yes, you will go from the inside and you will cut the prostate gland because no venous plexus is there. But the thyroid operation, you will go from the neck side, from the outside, and then you will do the thyroidectomy operation and you will remove without touching the venous plexus. Getting the point? So this is the one very, very important concept you will learn in the surgery, but this concept is coming from the our, yes, you can say anatomy. Very important fact. Now try to observe about the relation of the thyroid gland. We are cutting the thyroid gland, so you can observe thyroid gland is having the, yes, you're looking the thyroid gland from the top. So it is having the anterior border, it is having the posterior border. Also there is the lateral border. Okay, fine. Few books will not mention this lateral border also, but we are making a little bit easy. Okay, sir. Now it is having the, yes, lateral surface towards the skin. Yes, sir, lateral surface. It is having the medial surface. Yes, and this is our posterior or posterolateral surface. Okay, sir. So you can say there are the three border: anterior border, posterior border, and the lateral border. Many authors, they are not mentioning the lateral border, only the two borders. Three surfaces, sir: lateral surface, medial surface, and posterolateral surface. Few author will say the lateral surface as the outer surface and inner surface. Both are attached with the help of the narrow isthmus. Okay, sir. Now look for the relation. Okay, so we are going to look these structures in the neck. So try to understand further. When you will cut this all, yes, here is the one simple diagrammatic presentation of the same thing. Okay, so learn this one. Sir, when you will cut, I am repeating for the two times. So look here, sir, there will be the outermost layer skin. Yes, sir, skin. Just below the skin, there will be the superficial fascia. Within the superficial fascia, there is a which muscle? Sir, platysma is also there. Okay, sir, platysma. So we are not drawing this all the things. Just for understanding, these are the lateral relation. Now look here, in the neck there is a one big muscle. Which big muscle, beta? Sir, there is the presence of the our, yes, sternocleidomastoid on its side. So these are your what, sir? These are the sternocleidomastoid. Now inside the sternocleidomastoid, you will see the strap muscles of the neck, from the sternum to the hyoid, from the sternum to the thyroid. So you will observe there is a presence of the sternohyoid and the our sternothyroid muscle. Yes, sir, it is our sternothyroid. Also, there is the omohyoid muscle in the neck. Do you remember superior belly of omohyoid, inferior belly of omohyoid at the scapula? So this is the our omohyoid, which belly, superior side. Okay, so 1, 2, 3, 4 muscles. And now there is the our presence of the thyroid gland, two lobes which are attached together with the help of the isthmus. Okay, sir. So easily you can remember these are the lateral surface structure. Okay, how? Same thing I had drawn here. So what are the lateral surface relation? Can you see here? Again, skin, then superficial fascia with the platysma. Okay, sir. And then there is the deep fascia of the neck, that is investing layer of the deep cervical fascia. Yes. And then there is the layer of the sternocleidomastoid. Then you are observing, sir, there is sternohyoid, omohyoid, and there is our sternothyroid muscle. So these all are your lateral relation I had written here. Now, can you observe the relation on the posterolateral side? Yes, sir, posterolateral side relation. So it is very easy because just posterior and the lateral there is our carotid sheath. We all know the different structures at the carotid sheath. So within it, you will see the internal jugular vein superficially, the common carotid or internal carotid artery at the deep. In between them, sir, there is the vagus nerve, and behind to it there is a sympathetic chain. Do you remember on the front side there is the ansa cervicalis? Okay, sir. So these are the posteriorly and lateral relation. Now few more things I am going to tell you, sir. At the back side, definitely there is the vertebra. Yes, sir, this is our vertebra. So in front of the vertebra, there is our one fascia. Sir, this is our prevertebral fascia. Okay. Now look, in front of the vertebra, sir, there is the esophagus, and in front of the esophagus, there is the our trachea. Yes, I told you the mnemonic earlier. VOT. Yes, कल के नेता कहते थे तुम मुझे खून दो मैं तुम्हें आजादी दूंगा. आज के नेता कहते हैं तुम मुझे वोट दो मैं तुम्हें बर्बादी दूंगा. Yes, VOT is your mnemonic. V for vertebra, O for esophagus, T for trachea. Okay, sir. In front of the trachea there is the our thyroid gland. Fine. Now look, observe here, sir. There is the our, yes, group of the lymph node just behind the esophagus. Upper part of the esophagus is also known as the pharynx. That's why this is our group of the lymph node just behind the pharynx. So this is your what? Retropharyngeal lymph node. Okay, sir. We all know along the posterior border of the thyroid gland, there is the location of the parathyroid gland. So we are drawing the parathyroid gland also here. Now, can you observe, sir, this is the posteromedial surface. There is a thickening of the connective tissue on the posteromedial surface, and it is getting attached. Yes, it is a thickening of the false capsule also, you can say, and it is attached to the our, yes, thyroid gland. This is nothing, this is our suspensory ligament of Berry. Okay, And one very important question, in between the our trachea and the esophagus, there is a presence of the recurrent laryngeal nerve. Remember this MCQ, the recurrent laryngeal nerve is located in between the tracheoesophageal groove. Tracheoesophageal groove, there is the our right and left recurrent laryngeal nerve. Also one thing you can observe for your different topics, that deep fascia of the neck, deep cervical fascia of the neck, it comes and then it splits and encloses the sternocleidomastoid. Yes, it is enclosing the sternocleidomastoid as well as our the posterior layer, investing layer of the deep cervical fascia. It is enclosing the trapezius muscle also. Agree, beta? Fine. So these are the points which you have to remember. Okay, sir. So now I am going to look. I am going to tell you the medial relation. Sir, thyroid gland medially it is related with the two tube. Yes, trachea and esophagus. It is related with the two tubes, trachea and the esophagus. Yes, try to understand this one. Okay, sir. Each lobe is having the one apex, one base, three surfaces, three borders. Many authors are saying the two borders also. Okay, sir. Yes. Can you see there is the one apex, there is the one base. Fine, sir. Apex is up to the sternothyroid muscle attachment. So there was the one question had been asked, in case of the thyroid enlargement, which structure is preventing the upward extension of the thyroid gland? Answer is the our sternothyroid muscle. I am telling you here. Can you see this diagrammatic presentation? Sir, this is our, yes, thyroid cartilage. Fine. In this thyroid cartilage, can you observe there is the our oblique plane where different structures are attached? Yes, sir. Muscles attached on the oblique line of the thyroid cartilage. Can you see there is the presence of the thyroid to hyoid attachment of the muscle, thyroid muscle. Can you see there is another muscle sternum to the thyroid, so that is the sternothyroid muscle. And here is also the attachment of the inferior constrictor muscle of the pharynx. So these are the three structures which are attached. Now look, the thyroid gland apex portion is extending up to this oblique ridge. This is the enlarged view, sir. This is our diagrammatic presentation of the thyroid cartilage. Here you can see the cricoid cartilage, and this is the your, yes, tracheal ring. So the membrane between thyroid and cricoid, that is the, yes, cricothyroid membrane, and between the cricoid and trachea, that is a cricotracheal membrane. Fine. Now observe, this is your apex of the thyroid gland. Fine. Lateral lobe. Now you can observe this is the presence of the muscle sternum to the thyroid. Yes, it is coming, originating from the thyroid and attached, originating from the sternum and inserting into the thyroid. So this is the sternothyroid muscle. Yes, it is attached here. So if there is the extension, enlargement of the thyroid gland, it will be prevented by which muscle? Answer is the sternothyroid muscle. Okay. Also you can see the thyroid muscle is in between the thyroid and above is the hyoid. So there is the our thyroid muscle attached to the oblique line, and you can see there is the inferior constrictor is attached below to it. Also you can observe one thing, that here is the relation of the superior thyroid artery and external laryngeal nerve very close to it. Okay, sir. So just for one MCQ, your AIMS question, INICT, I told you this fact, that which structure is preventing the upward growth of the apex of the thyroid gland. Your answer is observed according to your Vishram Singh sir anatomy textbook. Answer is the clear cut, that is sternothyroid muscle. Okay. Now look for the our next concept, base. Base is encroaching up to the fifth tracheal ring. Isthmus is second to fourth tracheal ring. MCQ. You can remember also that the base is just below the isthmus part. Isthmus is ending at the T4 tracheal ring. So this base is ending up to the T5 tracheal ring. Agree, sir. Now look, there are the three surfaces. Sir, there is the lateral surface, there is the medial surface, and there is the posterior surface of the thyroid gland. Okay, sir. And there are the three borders. What are the three borders? Sir, entry border, posterior border, and lateral border. Many authors, they are not considering the lateral border, but just to make easy, we are doing the three surface and the three borders. Agree, sir. Now look for the next. Sir, we are looking for the relation, deep relation. I told you the deep relation or the medial relation. Yes, sir. We had seen the lateral relation, we had seen the posterolateral relation, but for the deep relation or medial relation, magic of two. There is a presence of the two tube. What are the different two tubes? Sir, one is a trachea and another is esophagus. It is very easy. And two nerves. I told you the recurrent laryngeal nerve is located at the tracheoesophageal groove. So recurrent laryngeal nerve. But one more nerve, the nerve supply of the cricothyroid, that is the external laryngeal nerve, is located here. Okay. And two muscles. So there is a cricothyroid at the deep and inferior constrictor muscle. So this is the way how you can remember, because when you will perform the surgery for the thyroid gland, you have to go layer by layer, skin, then superficial fascia with platysma, then a deep fascia, then inside you will retract the sternocleidomastoid, sternothyroid, sternohyoid, then you will reach for the thyroid gland. Okay. But you have to be aware, because posteriorly and laterally there is a carotid sheath, carotid vessels, very important. So don't damage them. And medially there are the two tube, there are the two nerves, and there are the two muscles. Don't damage this structure. Very important integration. Yes, you can observe in this image based preparation once again for all of you. Sir, this is our hyoid bone. Sir, here is our thyroid cartilage. Sir, there is presence of the cricoid cartilage. Then here is our tracheal rings are present. You can observe beautifully, sir, this is the presence of our thyroid gland. Yes, sir, this is our thyroid gland. Okay, yes, sir, this is our thyroid gland. Now try to catch this point, sir. This is our common carotid artery, which is dividing into the external and internal carotid artery. Okay. Now this external carotid artery is giving the branch to our thyroid gland. Definitely that is our, yes, superior thyroid artery. Yes, sir, superior thyroid artery. And in the similar way, this is our subclavian artery, which is giving the thyrocervical trunk. I will teach you. So it is giving the inferior thyroid artery, which is supplying from the inferior side. Okay, sir. Fine. Now look here, the nerves which are deeply related, muscles which are deeply related. Sir, deeply to at this part, can you see there is the presence of the two muscles? This is our inferior constrictor muscles, inferior constrictor muscle of the pharynx, and also in between the cricoid and thyroid there is a cricothyroid muscle. Two muscles. Simple. Yes. When you will observe the tube, so you can say, sir, this is the trachea and here is the esophagus. So two tubes are there. Now we are talking about the nerves. Focus here. Sir, this is the vagus nerve. Yes, sir, it is vagus nerve. This vagus nerve is giving nerve supply to the larynx from the superior side. So this is a superior laryngeal nerve. This is superior laryngeal nerve dividing into the internal laryngeal nerve, which is entering inside the larynx. You will see in ENT. And this is our external laryngeal nerve, which is going and supplying the cricothyroid. Yes. So the thyroid gland deeply related with which nerve? Answer is the external laryngeal nerve. Also, this vagus nerve is going down and it is giving one branch which is taking recurrent course and going to supply our larynx below the vocal cord. So the thyroid gland at the deep side, this dotted line is present. That is nothing. It is turning upside. Recurrent course. So what you will say? This is your recurrent laryngeal nerve. Getting the point? Yes, sir. So this is your external laryngeal nerve and here is your recurrent laryngeal nerve. Okay, beta, got the point? Yes. Now what I want to tell you one by one, step by step. We are going to look for the vascular supply. We had seen totally. There are the relation of the two tube, trachea and esophagus, two nerves, recurrent laryngeal nerve and external laryngeal nerve, two muscles, cricothyroid and our inferior constrictor muscle. Okay. Now we are looking for our blood supply. Remember, there are the two main arteries and three main veins. Okay, sir. 2 and 3. But variations are there. Sometimes 3 artery and 4 veins may be there. What are the different 2 main arteries? Sir, superior thyroid artery, MCQ. Sir, inferior thyroid artery, MCQ. I already told you in the face part, the superior thyroid artery is the external carotid artery. The old concept was the first branch of the external carotid artery, superior thyroid. But according to the 42nd edition of the Gray's Anatomy, yes, now it is not correct. The first branch of the external carotid artery is the ascending pharyngeal artery. So make update about this fact. Okay. Next, the inferior thyroid artery, sir, it is a branch of the thyrocervical trunk. And I told you in the upper limb part, this thyrocervical trunk is the branch of the subclavian artery, VITCD. Do you remember VITT for thyrocervical trunk? And that was the question from the AIMS INICT 2018 pattern. Sometimes there is the presence of the third artery, thyroid ima artery. Yes, surgeon is doing the surgery. They have to ligate these different blood vessels. But this thyroid ima artery, how many letters? Thyroid ima artery, 3 letters. It is present from 3% up to the 30% according to the surgery. Previously, the answer was a 3% individual, but now the 30%. So 3 to 30% individual they may present. Okay. So when the surgeon is doing surgery and suddenly he is observing this artery is present, then he said, "Ima, oh mummy." Okay. So when this artery is present, then then surgeon is getting, yes, just one fear. Why? Because it is abnormally present. So they have to get alert and they have to ligate it. Otherwise, there will be bleeding, shock, and more chance of the death. So you have to remember this thyroid ima artery. Okay. So it is important for the surgery. Now try to understand further. There are the, yes, this thyroid ima artery is the branch of what? Remember, it is direct branch from the arch of aorta. Otherwise, right brachiocephalic artery you can opt. I will show you the diagram. Okay. Now the venous drainage. So there are the 3 main veins: superior thyroid vein, middle thyroid vein, inferior thyroid vein. But sometimes there is the presence of the 4th vein of the thyroid, that is the 4th vein of the Kocher. Okay. These all are draining into the internal jugular vein, MCQ. But exception is asked. Remember, except the inferior thyroid vein which is draining into the brachiocephalic vein. I am going to draw the diagram also for. Okay. Look here, this diagrammatic presentation. Sir, this is our what? Thyroid gland. Okay, sir. Can you observe this is our arch of aorta? Fine, sir. Now this arch of aorta is giving the right brachiocephalic, B, subclavian artery, S, and this is the common carotid artery, C. BSC mnemonic I told you in the upper limb part. Now this brachiocephalic is dividing into the our cephalic artery, yes, right common carotid, and this is the your, yes, right subclavian artery. Yes, sir, this is our right common carotid artery. Now this common carotid artery is dividing into the internal and external carotid artery. Same story on the opposite side also. Okay. What the first fact you have to remember? The thyroid gland is supplied by, yes, superior thyroid artery. This superior thyroid artery is coming down, descending down, reaching near the apex of the thyroid gland, and it is dividing into the anterior and the posterior division. The anterior division is running along the anterior border and then superior border of the isthmus, and it is anastomosing with the same artery of the opposite side. Okay, fine. Now look what is happening with the posterior division. Sir, this posterior division is running posteriorly along the posterior border of the thyroid gland, and it is anastomosing near the presence of our superior thyroid gland. Yes, it is anastomosing with the our inferior thyroid artery which is coming from the thyrocervical trunk. Okay, sir. Very nice, very beautiful. We can remember. Okay. Now I am going to tell you about the our which artery, sir? Inferior thyroid artery. Inferior thyroid artery is the branch from the our thyrocervical trunk. Okay. Yes, it is the branch from the thyrocervical trunk, and it is dividing into the many branches. Yes, many branches. Fine. Okay. More facts I will tell you later. But okay, sir. One of them, they will go to the lower border of the isthmus and it will anastomose with the opposite side. Okay. Now see, this is the our sometimes presence of the thyroid ima artery. Few authors are saying 30%. Yes, it is the branch from the our brachiocephalic, right brachiocephalic, or sometimes directly it is arising from the arch of aorta. Okay, sir. I told you the notes I told you the diagrammatic presentation. Yes, remember few surgical point. The inferior thyroid artery is dividing into the many branches, and it is closely related with the recurrent laryngeal nerve, which is supplying the larynx, which is supplying all the muscles of the larynx except cricothyroid, which is supplied by the external laryngeal nerve. We all know. Now look, sometimes this recurrent laryngeal nerve deeper in aspect, sometimes it is running above the our inferior thyroid artery. So this is a very important fact, that recurrent laryngeal nerve is closely related with the inferior thyroid artery. Okay, and sometimes can you see this pattern? Recurrent laryngeal nerve is deep, then it is coming superficial, then again it is going deep. Means this our inferior thyroid artery is very close related with the recurrent laryngeal nerve. So whenever you will ligate this inferior thyroid artery, the recurrent laryngeal nerve will also get ligated, damaged, and this is supplying all the muscles of larynx except cricothyroid. So one muscle, posterior cricoarytenoid, is also involved, and this posterior cricoarytenoid, sir, this is also known as the safety muscle of the larynx, because it causes the abduction. My every point is MCQ. It causes the abduction of the vocal cord, so the breathing is possible. So if there is the ligation of the inferior thyroid artery, suppose there is a damage to the recurrent laryngeal nerve, in that situation, paralysis of the posterior cricoarytenoid. In that situation, the our safety muscle of the larynx, posterior cricoarytenoid, has gone. Means no abduction, means no oxygen inside, no carbon dioxide outside. Problem will be there. Yes, there is the chances of the death. So this relation is very important for the surgery. Agree, beta? Getting the point? Now look here, the same thing. Again revising, sir, the superior thyroid artery surgery integration. The superior thyroid artery, it is dividing into the anterior division running along the anterior border of the thyroid gland, and then it is anastomosing with the same artery on the opposite side. While the posterior division, it is running from the apex along the posterior border and ending anastomosing at the level of the superior parathyroid gland. Okay, it is anastomosing with the inferior thyroid artery. Yes, the inferior thyroid artery, this is the your subclavian artery. There is our thyrocervical trunk, F shaped. So what are the branches? Sir, I told you SIT, sit. Please go for our upper limb video. S for suprascapular, I for inferior thyroid, and T for transverse cervical artery. So this inferior thyroid artery is dividing into the many branches. Ascending branch is anastomosing with the posterior division of the your superior thyroid artery, and there is the our different many other branches, inferior divisions. It is dividing into the many divisions and supplying the thyroid gland. Yes, the inferior parathyroid is located on the downside along the posterior border. Okay, so this is another important fact. Parathyroid gland, total 4 in number, 2 superior and 2 inferior. You are looking from the lateral side, only single seen in this image. So the superior parathyroid gland, it is supplied by it is supplied by what? Sir, the superior parathyroid gland is supplied by the superior thyroid artery as well as inferior thyroid artery. But the inferior parathyroid gland, only it is supplied by the inferior thyroid artery. So MCQ, which is the main artery for the parathyroid gland? Definitely your answer is the inferior thyroid artery, if you have to opt one answer then. Okay, and also can you see which nerve is related? Can you observe here? Sir, the superior thyroid artery is close to the external laryngeal nerve. Okay, and then can you see this nerve is deviating away? This is your external laryngeal nerve. It will supply to the cricothyroid muscle. Okay, so what you have to remember, the superior thyroid gland, it is closely related with the our external laryngeal nerve. So if you have to ligate this artery during the surgery, you will ligate near to the gland, because if you will ligate this artery away, you will damage the external laryngeal nerve also. So you have to remember, the superior thyroid artery is closely related with the external laryngeal nerve. It should be ligated near to the gland. This is your mnemonic saying. And your old concept that inferior thyroid artery is closely related with the recurrent laryngeal nerve. So if you will ligate near to the gland, the inferior, the recurrent laryngeal nerve, yes, remember, okay, this is also getting damaged. What I want to tell you, try to understand, this is related close to the gland, near to the gland. That's why our old concept was saying we have to ligate this artery away from the gland. So what you have to remember, recurrent laryngeal nerve R, it is closely related with the inferior thyroid artery I. Yes, that's why you have to ligate away from the gland. So this is your mnemonic, Riya Sen. So there was the one old Bollywood heroine, beautiful heroine, Riya Sen. You can remember on her name the fact, Riya, Riasen. R for recurrent laryngeal nerve, I for inferior thyroid artery, A for away ligation. While Sen, S for superior thyroid artery, it is related with the external laryngeal nerve. It should be ligated near to the gland, near ligation. Okay, fine. This fact will be useful in anatomy as well as ENT, surgery, medicine, this all the subject. So Riasen is very important. But one recent update that surgery, Seviston, Love and Belly, all are saying both arteries should be ligated near to the gland. Why? This is the update. Try to understand again. Because if you're ligating away, in that situation, all the fine branches, they are going dead, ischemia, necrosis, and the inferior thyroid artery is the main artery which is supplying the parathyroid. So if you will ligate away, the parathyroid ischemia is there, and if there is a parathyroid ischemia, then calcium metabolism is affected. So nowadays, the new concept, you have to ligate this artery also, both arteries you have to ligate near to the gland. And remember, when you're ligating, you have to ligate this, you have to ligate this, you have to ligate that one, but never ligate this particular artery which is supplying the parathyroid. You have to leave that one particularly, yes, untouched, so that parathyroid ischemia will not be there, calcium metabolism will not be affected. This is very important fact from the surgery. Again, same thing, the superior thyroid artery and external laryngeal nerve. So you have to do near ligation. While the inferior thyroid artery, it is dividing into the many branches. It is closely related with the recurrent laryngeal nerve. Okay. Now don't ligate this artery away from the gland. What we have to do? We have to just ligate each branch, meticulous surgery we have to do. Don't ligate artery supply parathyroid gland. Don't touch the arteries which are particularly supplying the parathyroid gland. So this is the MCQ. We covered main artery of the parathyroid gland. Yes. Answer is our inferior thyroid artery. This is the best answer. Superior and inferior both are correct. But if you have to opt one single, then inferior thyroid artery is the best. Okay, so inferior thyroid artery ligation you have to do. Yes, if you are ligating the inferior thyroid artery, then parathyroid ischemia is there. Then we are doing the biochemistry, physiology, and medicine integration. This parathormone is responsible for the calcium metabolism. So there is a disturbance in the calcium metabolism. Agree, sir? So calcium is important for the heart contraction. Yes. No calcium, no heart contraction. You all know the calcium is responsible for the plateau phase. Yes, zero phase, first phase, then second phase, third phase, fourth phase, antiarrhythmic drug. Skeletal muscle actin myosin contraction. Yes, you all know excitation contraction coupling due to the calcium, it will be affected. And even in the our synapse, when there is an influx of the calcium, then release of the neurotransmitter. These all are getting abnormal phenomena. So remember, the superior thyroid artery and inferior thyroid artery both are ligated near to the gland, and avoid branch supplying the parathyroid gland to avoid the abnormal calcium metabolism. Got the point, everybody? Fine. So these are the points which you have to remember. So you have to integrate this all the things in the medicine. Whenever there is a parathyroid hormone abnormality, yes, it is doing calcium abnormality, hypocalcemia, you will get the Trousers sign positive, you will get the Chostak sign positive, and the carpopedal spasm. In Trousers sign, what you do, there is an induction of the carpopedal spasm, carpal bone and the your metacarpal bone, these all are showing such kind of the flexion. Yes, the thumb is flexed, other fingers are flexed, but interphalangeal joint, they are extended. So this is the carpopedal spasm situation. You will see whenever you are tying the sphygmomanometer, decrease in the blood supply, so calcium is reaching less. So in that situation, what is happening, there is a carpopedal spasm. This is the Trousers sign, and this is the Chostak sign when you are tapping in front of the tragus. So there is the ipsilateral facial muscles contraction. Okay, so there is a contraction of the muscles. This is also due to the hypocalcemia. So you must remember in the medicine. Okay, so this is the beautiful integration. Now look for the next venous drainage. I am going to draw the diagrammatic presentation for all of you. Suppose this is our what? Sir, this is our thyroid gland. Right lobe, left lobe. Okay. Now see the veins. Sir, here is the our vein coming from the cephalic area, that is the internal jugular vein, right and left internal jugular vein. Okay, sir. Now here is the our subclavian vein, right and left subclavian vein. Now these subclavian veins are uniting and making the brachiocephalic. Yes. So this is the right side brachiocephalic. Here is the left side brachiocephalic. Left brachiocephalic is longer and right brachiocephalic is shorter. Now both are uniting and making the superior vena cava. I think there is no doubt. This is the very basic thing. Yes, this is the internal jugular vein. Internal jugular vein. This is your subclavian vein. Subclavian vein. Sir, this is our brachiocephalic vein on the right side, while this is the left brachiocephalic vein. Right and left brachiocephalic vein, they are making the superior vena cava, which is opening into the right atria. Okay. Now see, there are the thyroid vein. Very easy, very simple concept, sir. There is the presence of the superior thyroid vein. जिसको जो पास पड़ेगा वहां ड्रेन करेगा. Yes, the superior thyroid vein is close to the our internal jugular vein. It is draining into the internal jugular vein. Middle thyroid vein, it is also draining into the internal jugular vein. So easy. But there is the inferior thyroid vein. It is close to the brachiocephalic vein. So inferior thyroid vein says, I will drain into the brachiocephalic vein. Sir, this is the your MCQ. All veins are draining. All veins are draining into the internal jugular vein. The superior thyroid vein, the middle thyroid vein, except answer is the internal inferior thyroid vein. It is draining into the our brachiocephalic vein. But sometimes, again, this is surgery. Sometimes one extra vein may be present, fourth vein may be present. So that is the fourth vein of the Kocher or Cocker, whatever the pronunciation you want to do, you can do. Okay. Yes, it was studied by the father of the thyroid surgery. Yes, Kocher. So on his name, this is known as Kocher's vein, fourth vein. It is also close to the our internal jugular vein. It is also draining into the our internal jugular vein. So all are draining. You can see here, sir, the superior thyroid vein, middle thyroid vein, there is the our inferior thyroid vein. Sometimes it is single, sometimes it is double. Okay, so these all are draining into the internal jugular vein, except what you have to remember, inferior thyroid vein is not draining into the our internal jugular vein. It is draining into the brachiocephalic vein. Sometimes the fourth vein of the Kocher is present. It is also draining into the internal jugular vein. Very important facts for your surgery, for the identification of the blood vessel, for the ligation, to do the less and less bleeding and to become a great surgeon. Okay, now try to catch this point, the lymphatic drainage. See here, easily you can remember the thyroid is enlarged. Okay, there is a carcinoma situation. So this thyroid is draining. Yes, it is in front of this thyroid gland is in front of the trachea, in front of the larynx. So it is draining into the pre-laryngeal. It is draining into the pre-tracheal lymph node. Getting the point? Few lymph nodes, they are around the trachea. So paratracheal lymph node. These all are nothing. These are the group of the deep cervical lymph node. So also you can opt the deep cervical lymph node. Okay. Yes. So this is the one diagrammatic presentation. Sir, these thyroid glands, they are draining into the pre-laryngeal lymph node. They are draining into the group of the lymph node which is in between the internal jugular vein and digastric muscle, posterior belly of the digastric. So it is known as the jugulodigastric lymph node. Upper part is draining there. Yes, can you see the lower part is draining into the nodes along the recurrent laryngeal nerve, also in front of the trachea, so pretracheal lymph node. Also there is the one muscle, omohyoid muscle, inferior belly of the omohyoid, so it is draining into the our jugulo-omohyoid lymph node also. The isthmus lower portion, these may drain into the our pretracheal lymph node, and even finally they are draining behind the sternum, so retroesternal or the brachiocephalic lymph node. Don't make complication, just remember this one: prelaryngeal, pretracheal, paratracheal. Otherwise, one thing, deep cervical lymph node. Why? Because of thyroid carcinoma, it will spread through the lymphatic route. Okay, sir. Now the nerve supply. Nobody will ask, just two lines. What you have to remember, the middle cervical ganglion, mainly it is supplying the thyroid gland. Also the superior inferior cervical ganglion, they are also helping. Okay. Now what we have to see, the little points about the histology. When you will understand the histology of the thyroid gland, then you will be able to understand your pathology abnormality. So when you will cut the thyroid gland, you will see the follicles. Yes, sir. There are the different follicles. These are lined by our which kind of the epithelium? Cuboidal cells. Yes, all dimensions are equal. Please go for our histology part. But one update. When there is the hyperactivity, hyperthyroidism, in that situation, the cube-like cells, they are doing synthesis, overactivity, so they can convert into the columnar. But if there is the hypoactivity, hypothyroidism, in that situation, these cuboidal epithelium may convert into the flat squamous epithelium. Okay, so if thyroid gland epithelium is asked, the cuboidal epithelium is your best answer. But if hypoactivity is asked, then you can opt the flat squamous epithelium also. But if hyperactivity is shown, then you can opt the columnar epithelium also. So this was the one INICT controversial question which we discussed recently. Okay, sir. They are secreting the T3, T4 hormone. Yes, they are secreting the thyroid hormone, which is stored within the our lumen of the follicle, and outside to this follicle you will see the parafollicular cells. Yes, there are the blood vessels. Also the parafollicular cells will be seen, which are responsible for the synthesis of the calcitonin. Okay, sir. Now try to understand further thyroid gland development. We all know, sir, there was the our location of the tongue. Here there is the foramen of cecum, where you will see the V-shaped depression, that is known as the sulcus terminalis. In front of this sulcus terminalis, this is the anterior 2/3 of the tongue, and here is the posterior 1/3 of the tongue. So this is your what? Sir, here is the foramen cecum. The thyroid gland development, which is the first endocrinal gland of the body, it starts to develop at the foramen cecum. This is the diagrammatic presentation, sir, foramen cecum. So here is the endodermal thickening first. Now this endodermal thickening is prolonging within the tongue and making one duct-like structure. Yes, it is related with the thyroid gland. That's why thyro. It is occurring within the tongue. That's why glossal, thyroglossal. Yes, it is duct-like structure. Now this thyroglossal duct is extending, growing within the tongue and going down, and it is bifurcating at the lower end. So it is making the bifid lower end of the thyroglossal duct. Yes, sir, there is a bifid lower end of the thyroglossal duct. Now observe in the next, sir, the thyroglossal duct, it is coming down, growing down in the neck. It is showing the two different lobe. Yes, the thyroid gland, it is developing from the what? Answer is the thyroglossal duct. MCQ. Also, I told you during the development of the pharyngeal apparatus, in the pharyngeal apparatus video, you will see there is the growth of the ultimobranchial body. Yes, lateral thyroid element is coming from our pharyngeal apparatus. It is encroaching within the our developing thyroglossal duct, and in this way, it is participating in the formation of the C cells. Also, you can say parafollicular cells, which are responsible for the secretion of calcitonin hormone. So these are making the our thyroid lobe. The ultimobranchial body, it is making the C cells, and here is the our fusion, the narrow part, the middle part which remains narrow, but these parts developing more, making the lobe. That narrow part is the isthmus, a small remnant along the upper border, that is making the pyramidal lobe. Okay, and the thyroglossal duct is obliterated. But now the congenital abnormality you can understand easily. See here, sir. Okay, one time again course. Here is the mandible, sir. This is the our tongue, and you can observe the foramen cecum here. So the thyroid gland is developing from the foramen cecum, and it is going down at the original position in the neck. So it is having the course within the tongue. Yes, sublingual, just below the epithelium. Then it is running inside the substance, intralingular course. And then here is the hyoid bone. So it is reaching above the hyoid. So this is the suprahyoid course, and then it is reaching below the hyoid. So it is known as the infrahyoid course. Then it is reaching to the in front of the thyroid cartilage. So this is the thyroid position, and then it is reaching to the in front of the cricoid cartilage. Yes, it is your cricoid location, and then thyroglossal duct is reaching here, developing properly. But sometimes excessive descent, it is resulting within the our development of the thyroid gland in the thorax. So this is the intrathoracic course. Now see, there is the abnormal position of the thyroid gland. How you can remember in your ENT medicine, it will be helpful. Sometimes this descent of the thyroid gland, the train of the thyroid gland, it is stopped. So the thyroid is developing at this part, that is the lingual, or you can say sublingual thyroid. Sometimes thyroid gland is getting stopped within the tongue. So you will say the intralingual thyroid gland. Sometimes the thyroid gland is reaching above the hyoid, and here there is a development of the thyroid above the hyoid. So it is known as the suprahyoid thyroid. When it is reaching below the hyoid bone, then you will say infrahyoid thyroid. Yes, here in front of the our cricoid and thyroid, this is the normal position, but sometimes it is reaching inside the thorax. Yes, so that is the intrathoracic thyroid. Also you can say retroesternal thyroid. Remember, there is a paraneoplastic syndrome. Paraneoplastic syndrome is struma ovarii. That is a different situation. That is a paraneoplastic syndrome. But this thyroid gland is found in the course of the thyroid gland. Okay, so you will see this all the things in your clinical, but the basics are coming from the our anatomy portion. Now look here, more point. I told you this is the our thyroid gland. Sir, there is a true and the false capsule. Yes, sir, here is a capsule. So this false capsule, prevertebral fascia. Yes, this is the pretracheal fascia. It is getting thickened on the posteromedial side and making the suspensory ligament of the berry. At the back side, you will see there is the our inferior parathyroid and the ascending branch of the inferior thyroid artery. Okay, so these are the points which you have to remember. Yes, inferior parathyroid gland is located along the posterior border, and here there is the anastomosis between the our superior thyroid artery posterior division and the ascending branch of the inferior parathyroid artery. Okay, so few points regarding the our parathyroid gland. Yes, there is a presence of the two superior parathyroid gland, two inferior parathyroid gland along the posterior surface, posterior border. Yes, the superior parathyroid gland, they are consistent in position. They are located at the site of the anastomosis between superior and inferior thyroid arteries. But the inferior parathyroid gland, it is variable in position. Okay. Yes, the main artery which is supplying the parathyroid gland, the main artery is our inferior thyroid artery. Superior parathyroid gland is supplied by superior and inferior thyroid artery, both anastomotic part. But the inferior thyroid artery is only artery which is supplying the inferior parathyroid gland. So if one answer you have to opt, this is the MCQ, which is the main artery supplying to the parathyroid gland. Answer is always inferior parathyroid gland. Now look for this our parathyroid gland histology. Sir, parathyroid gland, it is related with the thyroid gland posterior border. So in section of the parathyroid gland, you will be able to see the thyroid follicle also. Now this parathyroid gland, they are enclosed in separate capsule. Within the parathyroid gland, you will see two types of the cells. The principal cells, chief cells, these are most abundant in number. Yes, these are most abundant in number. These all are the principal cells. But can you see the eosinophilic cells, oxyphilic cells? These are also found, they are less in number. And in between them, you will see the connective tissue and the capillary. So what you have to remember, two types of the cells. Parathyroid gland, there are the two types of the cells. Chief cell, also you can say the principal cell. MCQ, these are responsible for the parathormone secretion, while the oxyphil cells, they are supporting cells, they are helping, they are supporting the chief cells, but they are not directly releasing the parathormone. So this histology part will be helpful for your clinical. Now see the different clinical points which you will learn in your medicine, surgery, ENT, other subjects. Inflammation of the thyroid gland, so use the word itis. Sir, itis means inflammation. Rubor, tumor, dolor, calor, functionalism. Okay. So the first clinical thyroid inflammation, thyroiditis, it may be two type, sudden and severe, acute thyroiditis. Yes, slow progression, chronic thyroiditis. One more situation is there, that is subacute thyroiditis in between them. Then next clinical as usual, small tumor, benign tumor, big and dangerous tumor, malignant tumor. Yes, benign, it is related with the gland, that's why adeno and suffix is oma. So this is the thyroid adenoma. But malignant, it spreads by the lymphatic route. So you will use the term carcinoma. So that is a thyroid carcinoma. So in medicine and pathology, you have to learn four main types of the thyroid carcinoma: papillary carcinoma of the thyroid, Hertel carcinoma of the thyroid, anaplastic carcinoma of the thyroid, and the follicular carcinoma of the thyroid gland. Okay, sir. Now look, function. When we are talking about the function, then two types of the function. Yes, hyperthyroidism and hypothyroidism. Okay, sir. Hyperthyroidism. So there is an autoimmune origin. Yes, sir. Autoimmune origin, which is leading to the hyperactivity of the thyroid gland. That is our Graves disease. Now read in the physio, medicine, this all the things. But hypothyroidism, sir, if it is in the child, C for child, then it is the cretinism, hypometabolic activity. But if it is occurring in the adult, then you will see myxoedema, because myxoid connective tissue, the polysaccharide, the heteropolysaccharide, they are getting swollen and there is a edematous situation. That's a myxoedema, myxoedema. Okay. Now see, what is the goiter? Very important. Yes, generalized swelling, generalized enlargement of the thyroid gland. Remember, this is your goiter. What you have to remember, this is not seen in case of the hyperthyroidism. It is not only seen in case of the hypothyroidism. Yes, it is seen in both. It is found in hyperthyroidism as well as in hypothyroidism. Okay, so this is your goiter. Now we are looking for the thyroidectomy. Yes, whenever there is a cancer or in a dangerous situation, then you have to cut the thyroid gland and you have to remove. I already told you, tomy means cutting, stomy, stomy means opening creation, and whenever there is the ectomy suffix, then cut and remove. So thyroidectomy is surgical removal of the thyroid gland. Okay, sir. Now look here, the congenital abnormality. I told you already, sir, sometimes there is a no development of the thyroid gland, thyroid agenesis. Sometimes abnormal position of the thyroid gland, that is the ectopic thyroid. I told you the lingual, yes, sublingual, intralingual, supraoid, infraoid, yes, in front of the thyroid. Okay, and sometimes intrathoracic. Fine. So these are the abnormal position. Now one more topic, that is the thyroglossal cyst, thyroglossal fistula, and thyroglossal sinus. In embryology part, I will teach you, sir, there is the any embryonic structure. Later it gets disappear, but sometimes it remains same with the two opening. Then it is the fistula. But sometimes one opening is getting obliterated, then it is known as a sinus. And sometimes the both ends are getting closed, and yes, it is presenting with the closed cavity. So this closed cavity filled with the fluid or gas, that is known as the cyst. So there are the situation like the thyroglossal fistula, thyroglossal sinus, thyroglossal cyst. These all are the situations. Now look here, few more things. Sir, I told you this thing in embryo, there is the normally it is getting obliterated, so it can make cyst, fistula, and sinus. No end, cyst. Two ends open, then fistula, and one end open, then sinus. So catch this point. Sir, this is our tongue. Here is the thyroid gland. Okay, so at embryonic time, there is the duct, thyroglossal duct. Later it is getting obliterated and it is helping in the function of the levator glandular thyroid, and lower part is making the pyramidal lobe. Okay, but now try to understand, suppose the both end persisting, so this is resulting into the fistula, thyroglossal fistula, toe opening. But when both the ends are obliterating and making one closed cavity, so this is our thyroglossal, yes sir, cyst. Sometimes only one end is open, remaining end is closed. One end, that's why you will say sinus. So simple. Anatomy is very beautiful subject. If your anatomy is strong, other all the medicine, surgery, ENT, every subject will get stronger and stronger. Getting the point, beta? Now try to catch the focus areas from this video. Yes, you must study the thyroid and isthmus location. Sir, thyroid is located from the C5 to T1. This is important. And the isthmus tracheal ring, T2 to T4 tracheal ring, it is important question. Important relation of the thyroid. I had drawn the diagram. I told you the concept. Arterial supply and the relation of the nerve. Okay, so you must remember the RIA same relation, but also what you have to remember, this is old concept, the new concept is different. The both the nerves you have to ligate near to the gland, and you have to avoid the parathyroid ischemia. Then you must study the venous drainage of the thyroid for the surgery purpose, four veins of the thyroid gland, and then clinical. Nowadays the direct question from the anatomy they are not asked, clinical based questions are asked where the anatomy is hidden. Now look for the revision capsule. The inferior thyroid vein drains into the NEET PG 2012 question. Remember, all the thyroid vein, they drains into the internal jugular vein except inferior thyroid vein, it drains into the brachiocephalic vein. MCQ. Lymphatic drainage of the thyroid gland mainly one single best answer, deep cervical lymph node. Otherwise, if specified, then you can say the pretracheal, paratracheal, the prelaryngeal lymph node. Then inferior thyroid artery is related to what? I told you the mnemonic RIA sane. Yes, sir. R for recurrent laryngeal nerve, I for inferior thyroid artery, while the S for superior thyroid artery, it is related with the external laryngeal nerve. Important for the surgery. Yes, suspensory ligament of Berry, it fixes thyroid to what? So remember, it is not the thyroid cartilage, but it is the cricoid cartilage. This is important question. Now look for the question, NEET pattern 2015. Yes, question was isthmus of the thyroid gland overlies. I told you in the concept, this is related with the second to fourth tracheal ring. Thyroid gland was extending from the our oblique ridge of the thyroid cartilage up to the fifth tracheal ring, but isthmus is second to fourth tracheal ring. Next question, inferior thyroid artery is the branch of, so this is the NEET pattern 2015 as well as INICET AIMS 2018. So remember, it is the branch of the thyrocervical trunk which is giving the branches SIT. S for, you can remember, suprascapular artery, I for inferior thyroid artery, and T for transverse cervical artery. So these are the different points at the end of this session. Remember beta, life is like a boxing match. Defeat is declared not when you fall, but when you refuse to stand again. So fall, but again stand, fall, again stand, fall and again stand. So remember, always I say to my dear students, आदमी या तो जीतता है या फिर सीखता है, आदमी हारता कभी नहीं है। आदमी हारता उस दिन है जिस दिन वो कोशिशें करना छोड़ देता है। क्यों डरे जिंदगी से? अरे क्यों डरे जिंदगी से कि क्या होगा? अरे कुछ नहीं होगा तो कम से कम तजुर्बा होगा। तो गिरो, लड़खड़ाओ, लेकिन फिर से उठो, बाउंस बैक करो। ऑल द बेस्ट, गॉड ब्लेस यू ऑल।